My topic is simulation in anesthesia.
Hmm.
Simulation is defined as a set of techniques to replace or amplify real experiences with planned experience. Simulate refers to give or create the effect of or to imitate. Simulation in medical curriculum means recreating or imitating part of some clinical scenario for the purpose of training or evaluation. Simulation can be used in anesthesiology to train the residents. The simulation scenarios can be used for orientation of the new procedures, exposure to uncommon clinical scenarios, assessment of knowledge. Simulation accelerates skill acquisition, improves skill retention, and reduces the extension of the skills. The three components of simulation experiences are initial briefing, the actual simulation and experience, and debriefing. Debriefing is the chief component of simulation that allows the trainee to understand the decision making, which is the first step in changing the clinical practice for the better patient outcomes. Classification of the simulators that based on the type of interaction, there may be hardware based simulators where the models for epidural and nerve blocks have been made, and fruit models for epidural training has been made, and screen based simulators which are computer based. Virtual reality based simulators which are used for IV access training and ultrasound guided regional anesthesia. Human-based simulators, which are role-play scenarios in which the members of the staffs are used as an actors. Based on the type of teaching, the simulation helps in acquiring knowledge, skills, drills, and performance. Rationale for using simulation in anesthesiology. Anesthesiology is a hands-on specialty, and the way to master a skill is to practice it again and again. So simulation provides a safe learning environment where the residents and students can be taught, practice, and be evaluated on the technical skills like intubation and ventilation without putting a patient at risk. Widespread use of simulation in anesthesiology is to provide crisis management training, which allows to experience the clinical scenarios that are infrequent on daily practice but critical for anesthesia practice, like use of double human tubes, bronchial blockers for lung isolation, etc. Uses of simulations can be used for BLS and ACLS training, and in airway management where the new airway devices can be demonstrated, and in regional anesthesia especially using ultrasound, in obstetric anesthesia where the improvement of technical skills are trained, non-technical and teamwork skills are trained, and individual clinical competence and safety of the clinical environment has been developed. The technical skills like epidural anesthesia has also been used in simulation. Then in cardiothoracic anesthesia, like recent technical and research advances which make to learn complex skills in a low stress environment. And basic concept of ecography, esophageal echocardiography can also be learned using simulation. And new technologies like infusion pumps can also be demonstrated. And in acquiring non-technical skills like anesthesia, crisis resource management, communication, leadership, situational awareness, and teamwork and decision making have been the uses of simulations in anesthesia. That's it, sir.
Okay. I don't know whether the pronunciation you made is right or not, because mostly we say simulation in anesthesia and not simulation. So
Okay.
simulate means copy or mimic. That is the meaning of the word simulate. And
Okay.
so simulation, as you rightly said, helps in learning process. Earlier it was used in the, where did we copy this from? Is it we evolved it into the medical field directly, or did we copy it from some other industry? This simulation practice, was it originally developed in the medical curriculum, or is it copied from some other industry where they use it on a regular basis for safety sake?
Uh,
It was borrowed from the aviation industry. People, the pilots who drive, right? The planes. The aviation industry only started the simulation training program where they wanted to teach their pilots how safely to drive a plane and land it safely, take off safely, and what to do if they encounter a cloudy area while in the path of flying, and what will you do when you have to do an emergency landing because of some fuel shortage or fire and all those things. So the original concept was from the aviation industry, and they found that when you give a training to tackle crisis situations when the pilots are in a relaxed mode, they can remember those steps and follow that in a crisis when it is actually happening. Okay, that is the reason why this simulation, which was given as a training part for the pilots who are flying the aircraft, medical people thought that similar things happen to us also, because in fact anesthesia is compared to the action of a plane being taken off and then being landed. So your induction and extubation recovery should be as smooth as you take off and land out in a flight when you go. So that is the reason why we thought of introducing this simulation in anesthesia, or first medical also. But among the medical specialties, anesthesia was the first to imbibe this particular concept. And then the critical care, surgery, medical, and other people followed, and then they started utilizing the same technique that we used there. But we as anesthetists can lift our collars and say that we were the ones to introduce this concept of simulation in medical practice itself. Okay, so I'll just show you my screen to. So why simulation in anesthesia training is gaining importance? So over the years, the use of simulation has gone from low fidelity to high fidelity models. They were able to improve on the mannequins and models that they were using to demonstrate how to practice various skills. Okay, so this is the main reason they were able to improve on the models that they were using from what is called the low fidelity to high fidelity groups. And the they have made it look like a real patient with pulse, heart sounds, airway that can be programmed, and all these improvements in the mannequins and the models that we use. That is the reason why this is almost become part and parcel of the training of residents and other physicians. And all of you know that whenever you go for a CME or a conference nowadays, there are workshops conducted before the CME program, and one of them will be anesthesia simulation program. So research and methodology will be one, and simulation will be one, and focus is another. These are all common workshops which are repeatedly conducted nowadays, and all of you must have had the opportunity to under one or two of these simulation programs. So anesthesia has often been compared to the aviation industry. Both are high risk with a minimal tolerance for error, and passengers entrust their lives to pilot, while patients undergoing anesthesia entrust their lives to the anesthesiologist. Okay, so we must do our best to the patient, and a small error in our conduct can cause morbidity and mortality to the patient. And that is the reason why we have to give them a good training before you venture on to practice your anesthesia in the live patient. So one of the most important reasons cited for improvement in the safety of aviation industry has been the routine use of aviation simulators in the training of pilots. So it is rational to assume a relationship between simulated training and patient safety in medicine also. So simulation in anesthesiology is no longer a research fascination. Earlier it was thought that you can do a lot of research using simulation, but now it is part of resident education or training. So what is exactly simulation? How is simulation used in training? Simulation in medical curriculum means recreating or imitating part of some clinical scenario for the purpose of training or evaluation. So that is the meaning of simulation in medical curriculum. And simulation scenarios can be used for orientation to new procedures, exposure to uncommon clinical scenarios, and assessment of knowledge. Actually, the simulation training originated from which particular procedure? Can you tell me, Sivasankari, which particular procedure started the concept of usage of simulation?
ACLS, BLS.
Cardiac life support. Okay, so that is where we initially wanted to revive a patient. We wanted to teach first the medical people, then paramedical people. Now we go on to do even the common lay people by the Coles only technique, compression of then life support. So this is where we first thought of doing that. From there, we extrapolated it to use for doing a central line placement or putting a transesophageal echocardiography and exposure to uncommon clinical scenarios, because a cardiac arrest will not happen every day. So if you have a mannequin where you practice cardiac arrest revival every day, you will be learning all the points very easily, and when the real situation comes in a life scenario, you will be a better person to manage it rather than a person who is not trained in that properly. And it also gives you an assessment of your knowledge, how your skill you have gained can be assessed by asking you to repeatedly. We had a mannequin in Stanley way back in 1980s, bought by our chief from USA, where when all the intubation training was given by that. So invariably, as a beginner, when you use the laryngoscope, you always try to lever it on the upper jaw and the teeth. So in that mannequin, when you introduce your laryngoscope, even accidentally, if you touch the upper jaw tooth, then a red light will burn, which means that your technique is not right. So in that way, we used to practice that without touching the upper jaw, we have to nicely open the mouth and then introduce the blade in correct fashion without levering on the upper jaw. So that training was very useful by doing it on the mannequin again and again. So that is the reason for this particular training. So it accelerates skill acquisition, improves skill retention. That is, by repeatedly doing, you are able to retain that skill. Not only practice it on now and then, but you are able to reduce the extinction of skills. For example, if you are not a cardiothoracic anesthetist, you will not be in a position to do a transesophageal echocardiography routinely. But if you keep on practicing it on the mannequin, you can remember it at any time, and once you are given a chance to go and work in a cardiothoracic unit, you will be able to do it without any hesitation or difficulty. So the skill acquisition, improving or retaining the skill, and then seeing it that you don't forget the skill. All the three things are possible by using the simulation training. And helping with technical skills is also there. And most importantly, this is a short note question by itself in the examination. The ANS, anesthesia, non-technical skills. This is how the wording is given in some of the theory papers, which is a which has the components of task management, leadership, team working, situation awareness, and decision making. These 5 things are the components of what is called the. This is nothing to do with your spinal or epidural or intubation skill or putting in a central line. So this is a man management or a management of a crisis situation, how you manage, that is also possible with the simulation training. So apart from your anesthetic skills, you are given training in non-anesthetic skills like man management and crisis management also. And the non-technical skills are vital part of safety in emergency and crisis situations. So what are the important components of the simulation? Rightly, there are 3 components. One is initial briefing. That is, whenever you start the simulation, or those of you who have attended the simulation workshops in the conferences or CMEs, you all would have experienced. The person conducting the simulation workshop will first give you the briefing of the case scenario. Then they will demonstrate how actually you have to do the procedure. For example, the common scenario they will give you is you have administered a drug. Patient has developed an anaphylaxis. There is swelling of lips and face. Patient is having bronchospasm, difficulty in breathing, and he has rashes all over, and BP has crashed from 110/80 to 50 by non-recordable. So this is the initial briefing or case scenario they will give you. Then they ask you how to do that. Then you say immediately, I make a diagnosis of anaphylaxis, and the first drug of choice is adrenaline. So I will try to administer it by intravenous or intramuscular or whatever method. Then my treatment is for relieving the bronchospasm. Then my treatment is to correct the hypotension by giving fluids. So this is the actual management. Then after completing that management part, they will again go back and to review what happened, whether your first diagnosis is right, whether what treatment you have given is all right, whether you have followed all the steps correctly or made any mistakes in that, and that is called the debrief. So these are the 3 important steps of simulation: initial briefing, actual experience, and then the debriefing. So debriefing is the chief component of simulation that allows trainee to understand their decision-making processes and first step in changing their clinical practice for better patient outcomes. So during the actual management, if you have made any mistakes, that can be corrected by the debriefing. So debriefing plays a very important role in the simulation training. And what is the rationale of using simulation in anesthesiology? It is more of an interactive and innovative educational tool that could build confidence, improve clinical knowledge through practice, and enhance team performance also. That is by the ANTS training. And anesthesia is a hands-on specialty. You cannot just read your theory and become a good anesthetist. You should have good skill to do an epidural. You should have a strong non-shaking hand, and you should be able to identify the space correctly without making a dural puncture. All these things are hands-on training, and it's a specialty. Only way to master the skill is to practice it again and again. So that can be done in the mannequin or in the simulation lab rather than in a live patient when you don't have that much of volume to practice. And simulation provides a safe learning environment and can be taught, practiced, and be evaluated also without putting the patient in risk. That is the most important thing. And anesthesiology, in fact, is the pioneer to introduce the simulation in medical education. And this was instrumental in the development of high fidelity human simulation used for medical education. That is, earlier mannequins were just rubber human being like models, and we were taught only to do external cardiac compression. So we did not require much of a improvement or gadgets in that particular mannequin that was used for CPR training. But later, when we wanted to do the real simulation, we have to have bronchospasm, we have to have hypotension, we have to have unconsciousness, we have to have difficult airway. So all these things were incorporated, and that is what is called the high fidelity human simulation models that were introduced. So widespread use of simulation in anesthesiology also provides what is called crisis management training, is imparted by simulation. Now the clinical scenarios and the infrequent daily practice, but critical to anesthesia practice are that can be by examples are putting a bronchial blocker or a W tracheal tube, that you won't be doing it in every day unless you are working in a cardiothoracic unit. You are not you will not have the chance to use a W tube very often. So whereas if you have a mannequin and a simulation lab, and you can practice it every day also, and that will be handy when you are exposed to particular situation where you have to use it, rather than when you are not trained in that particular skill. So the predominating use of simulation and the educate in crisis management, that which also the routine anesthetic management, all can be done by the simulation. And in addition, uh, trainees will have hands-on training on can be given to non-anesthesiologists or paramedical people also. So it is not only for the anesthesia residents, but paramedical, nurse, anesthetist, theater people, everybody can be trained there. And there is limitation to teaching in the operating room. For example, if we have a list of 15-20 cases a day, the senior person will not have time to teach you each and every step of the anesthesia to all the residents, because they have to finish the work and complete the list. So the time to teach will be very limited in OT. So in that situation, patient care and education will be better if you use the simulation. And it's a risk-free environment, both for you. You don't have to increase your BP and pulse rate because it's not a live patient, and there is no danger to the patient also. Even if you make an esophageal intubation, you can remove it and re-intubate it to the trachea in a mannequin. But it gives you more tense moments when you do it in the live patient. So the risk-free environment is another added advantage. And how the mannequin and this simulator's history, how it is evolved. The first ever simulation was called the Lateral's Rescue Annie. So it was like this. You can see it is a rubber human-like model, and it is used mainly for CPR training. And it was simply designed to teach cardiopulmonary resuscitation, and the first true high fidelity model where it had all the features like a normal human being, like pulse, respiration, and the pupillary movement, of course, air entry, everything was there. That is called the Sim 1. And the Sim 1 was like a prototype of anatomically shaped chest, moved with breathing, eyes blinked, the pupils dilated, constricted, jaw opened and closed. So that is how the real human-like model, which is called the Sim 1, was created. And once the software was introduced into simulation, the mathematical models of physiology and pharmacology, and with the computer software, it almost resembled a normal human response. So that is the major advantage or the development in simulation labs, that nowadays you have the mannequins or the models which have almost all the human responses that you want to recreate. And it was first to introduced by uh, Philip J.H. and he named that as a gas man, which had all the pharmacokinetic models of anesthetic administration. And then in 87, David Daba of Stanford University, he also made a realistic physical simulation system, and which is called the Comprehensive Anesthesia Simulation Environment. And it was built primarily for helping anesthesia crisis resource management. This is another way the question can be worded in the examination. ACRM, that is anesthesia crisis resource management training, which is nothing but talking about the non-anesthetic skills of the anesthesia and anesthetic non-technical skills, or ACRS, or both are similar. And then there was one Dr. Gravenstein who created a Gainesville anesthesia simulator or gas, and it was a very sophisticated simulator which could imitate breathing, generate a pulse, EKG, and lung that followed normal physiological calculation, consume and eliminate gases accurately. So all these things are possible. And there were hidden sensors to functionally interact with anesthesia machine that recorded user action, which were used in providing feedback or the debriefing. So the simulators in use in the world today are updated version of the above simulators. So right from simple CPR training model, now we have come up to the stage where it may mimic a normal human physiology functions and mimic a normal human being. And the current state of simulation in anesthesiology is, it is a mode of interaction, screen-based, hardware-based, and virtually related. Then physiological model used is there, and there is used to teach predominantly psychomotor skills and cognitive skills of our trainees. Various uses of stimulation is in the airway management. It is primarily for the psychomotor skill, and fiber optic orotracheal intubation, which is a complex psychomotor skill, can be easily taught to residents because you don't get an opportunity to use a fiber optic every day, and simulation can cover the gap in the training. Then simulation in regional anesthesia that provides teaching of ultrasound guided regional anesthesia both in adults and in pediatric patients. Then simulation in obstetric anesthesia, where four broad uses of simulation are improvement of technical skills, non-technical or teamwork skills, individual clinical competence, and safety of the clinical environment. So all these things are taught in the simulation in obstetric anesthesia. And technical skills such as epidural anesthesia, estimating volume of blood loss can be taught using the simulator, and teach team communication skills also. And the volume of cesarean deliveries done under GA is now very much reduced. Everybody prefers only spinal as a first choice. So giving GA has considerably reduced. So that also can be trained in simulation labs, so that if there is a necessity, you will not be struggling to give GA for a emergency cesarean delivery. And simulation training will fill up the gap in the residency program training. And in cardiothoracic anesthesia, where you don't get much of an exposure during your training period, simulation will again help in getting you the required vascular access and other intricacies of cardiac anesthesia. And you can learn that in the short period of time, and that also repeatedly you can practice putting a central line or introducing a PE and chest drain tube. All those things can be learned in the simulation lab, and it can teach you the basic concept of PE and teaching non-technical skills. Again, the same thing that is available because of the videotaped and used in debriefing session. And simulation training is also known not only to self-report confidence but also the clinical performance. Okay, so that is all for the simulation in anesthesia. So what points you have to add is the main objective of simulation, how it has improved over a period of time. That also you have to include in your answer. Okay,
Yes,
from simple CPR training to now up to the various skills that you are able to practice and specialize. That is the way you have to shape your answer. Okay, right, good.
Thank you.